Good afternoon, everyone, and thank you for attending today's webinar, Nurse Triage Telehealth Services, a Solution to Physician Fatigue and Burnout, presented by Brad Lieberman, the co-founder of Triage. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the Q&A portion. Additionally, an electronic version of this presentation will be emailed to all participants following the completion of today's webinar, and a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Brad.
Thank you, Dawn. Good afternoon, everyone. My name is Brad Lieberman, and I am the co-founder and chief operating officer with Triage, a telehealth nurse triage provider. Thank you for taking the time to listen about a topic that is important to all medical practices. On behalf of the team at Triage, I would like to thank Dawn and Alex, as well as the entire Maryland MGMA, for making this presentation possible today. Before we get started today, I would like to share a little background about myself. I'm a registered nurse practicing in a busy emergency department. After seeing numerous patients present to the emergency department with simple complaints who became frustrated with long wait times, I started to notice the need for after-hours telephone nurse triage for primary care practices. After further discussions with patients, they often shared that they did not have a trusted resource to ask questions to help determine where and when they should seek care. These patients were spending countless hours in an emergency department because they did not have a professional resource to guide them to the best care setting for their condition. As I started to observe this situation over and over, I realized the best way to solve this problem was to empower patients to make informed decisions about where to seek care with the help of expert nurses via telephone triage. Out of this realization came the idea that telephone triage could also help medical practices reduce fatigue and burnout by helping to reduce the amount of phone calls required to be handled by on-call providers at primary care offices on nights, weekends, and holidays. Today, we're going to discuss provider fatigue burnout, some of the causes, some of the consequences of fatigue and burnout. We're going to help you identify some ways that you can measure fatigue and burnout in your practice setting, and also provide you with some real-world solutions to fatigue and burnout. I want to take a moment and acknowledge that during this presentation, we interchangeably use the term physician and provider. The information in this presentation is applicable to all frontline healthcare providers. However, some studies specifically focus on physicians, so we have maintained some of the original references to physicians where applicable. Now let's talk about fatigue and burnout. Provider fatigue and burnout is often referred to as a long-term stress reaction characterized by depersonalization, including cynical or negative attitudes towards patients, emotional exhaustion, a feeling of decreased personal achievement, and a lack of empathy towards patients and other providers. Oftentimes, we attribute fatigue and burnout to practitioners in the end stages of their career. However, any practitioner at any point in their career may experience symptoms of burnout. Another way to look at burnout is that it relates to your professional spirit of life. That is to say, your level of engagement in your practice and your outlook on how you approach interactions with patients and other providers. Burnout primarily affects individuals whose work involves an intense interaction with people. It can be said that practitioners and staff are allowed into the most intimate spaces of people's lives and often must deliver difficult news. All of this can certainly take a toll on everyone. It has been suggested that burnout is not unique to the medical field, however. Compared with the general US population, physicians work a median of 10 more hours a week, display higher rates of emotional exhaustion, and report lower satisfaction with work-life balance. With these statistics, it is clear that while burnout may not be unique to the medical field, it has a very real impact on providers in their day-to-day life and their career longevity in healthcare. The Mayo Clinic conducted a survey in 2015 to quantify one item of burnout, and the results show that there is a substantial difficulty with satisfaction with work-life balance among physicians as compared to the general population. The survey asked participants to respond to the statement, "My work schedule leaves me enough time for my personal and/or family life." According to the results, about 61% of the general population agreed with the statement, and only 36% of physicians agreed. Almost 50% of physicians disagreed with the statement, while only about 20% of the general population did not agree. Based on the results, it is clear that work-life balance is not something that a majority of physicians are happy with, and they suffer with at a higher rate than that of the general population. While many practices feel like fatigue is not a problem in their specific practice, evidence shows that fatigue is becoming more common and is likely occurring in some degree in every practice represented here today. Globally, 1 in 3 physicians experience burnout at any given time. Closer to home, the 2015 Medscape Physician Lifestyle Survey results show that 46% of physicians as a whole report feeling symptoms of fatigue and burnout, which is a 6.2 increase since 2013. Now, speaking specifically about family physicians, between 2011 and 2014, the burnout rate among family physicians had increased from 51% to an astounding 63%. Based on these staggering increases, it is clear that physician fatigue is on the rise and has definitely reached epidemic proportions. Now, the highest risk for burnout is among frontline care providers in certain specialties, including family medicine, internal medicine, and emergency medicine, as these providers are often burdened with high patient panels, complex patient needs, and demands for timely care. In a different study by the American Medical Association that reviewed changes from physician burnout from 2013 to 2017 showed similar results to previous studies. As you can see, the top 4 specialties maintain emergency medicine, OBGYN, family medicine, and internal medicine. Over a span of 4 years, both internal medicine and OBGYN have increased their rankings. The current rate for burnouts for specialties at the top are 55% for the OBGYN, 54% for family medicine, and 53% for internal medicine. These specialties have all gained around 10 to 12% of burnout in just 5 years. At this rate, burnout will affect every practitioner within the next 20 years unless we take meaningful action to reduce the demand placed on providers by the current way we practice medicine in our offices. As we've now seen the impact of fatigue on a variety of different practice areas, we're now going to examine some of the factors in daily practice that can lead to burnout. First, heavy workloads in practice are a prime cause of burnout. This should come as no surprise. Providers are expected to see a large panel of patients and then feel pressured to speed through physical exams and also feel as they're unable to adequately follow up with patients that need closer management. Next, inefficient work environments, including required pre-approvals for procedures, lack of adequate support staff, and even electronic health records can contribute to burnout. While it is unlikely that practices are willing to give up electronic health records as there is such a great effort to transition to them, they are not as effective as we had hoped they'd be. Many providers have great criticism over how their EHR has taken them away from their preferred practice. And this has definitely led to some practitioners to point to EHR as the direct cause of their burnout. Additionally, lack of flexibility in daily practice has taken a lot of the enjoyment out of practice. Many practitioners feel stifled when they're required to do certain workups or tests based on practice policy. While these practices are generally good from a managerial standpoint, they're not well received by practitioners, as these policies can be perceived as restricting practice and preventing true autonomy. Finally, difficulty with work-life balance is often cited as one of the biggest causes of provider fatigue and burnout. Time away from the practice is often some of the most important time for providers to maintain personal balance and healthy relationships with their support networks. When providers are tasked with taking call on nights, weekends, and holidays, they miss out on very important aspects of life and often feel their professional lives are at odds with their personal lives. These on-call shifts can be consuming, and a majority of these calls that the practitioner must field are not true emergencies and could safely be handled by a registered nurse utilizing standardized protocols. Now that we have identified the scope of provider fatigue, let's discuss the impacts of the problem. Fatigue impacts both practices and providers in different but important ways. The most apparent impact is the high turnover rate for providers. Oftentimes, providers sense fatigue and leave the practice for less demanding opportunities or reduce their hours to establish a better work-life balance. Staff are also impacted by provider fatigue. Oftentimes, fatigued providers have a hard time communicating with staff members and do not come off in a friendly manner, and that can make working with the provider challenging. Sometimes this behavior goes unchecked and becomes a source of stress on staff and can contribute to their departure from the practice. Additionally, fatigue can cause a lower quality of care and decreased patient satisfaction. Our patients are perceptive and can certainly tell when our focus is elsewhere. Fatigued providers are often poorly rated by patients and can leave patients feeling unsatisfied with the care that they are provided. This can often lead to patients seeking different care in different practices. Fatigue can also contribute to high medical error rates and increased malpractice risk as providers become less attentive and tend to not care as much about patient outcomes as they begin to suffer from burnout. The practice also experiences financial hardships from loss of providers in terms of decreased revenue as well as increased costs to train replacement staff. Individual providers experience quite a different set of consequences from provider fatigue, but they are still very important. Most notably, fatigue places a great strain on providers' support networks, including friends and family. This strain can severely impair their ability to cope with job-related stress. Inability to cope with this stress can lead to high-risk behaviors with tragic outcomes. Now, let's further examine the financial impacts of the loss of one physician on a practice. Conservative estimates place the loss of revenue at between $500,000 and $1 million per year for every physician a practice loses. This loss is greater in higher paying specialties. On top of this lost revenue, the cost to recruit a replacement physician is estimated to be around $90,000. Further, each provider that leaves the practice adds to the workload of other providers, and this has a cascading effect, causing more stress on the remaining providers and further accelerating the rate of burnout in the practice. If at the very least the practice manages to retain fatigued providers, there are still financial impacts to the practice that are not ideal. For every 1 point rise in burnout or drop in professional satisfaction, there's a 30 to 50% chance that a physician will reduce their personal work effort. This reduction in effort has a similar impact on other providers as if a physician was to leave the practice. There is a negative impact in productivity and a spread of burnout from one practitioner to the next as the workload shift takes its toll. Now, with these tangible and intangible consequences of fatigue, there's a good reason not to ignore this growing problem in practices today. Now, let's look at why practices have been reluctant to examine burnout and how you can identify the levels of burnout in your practice. Many practices understand that physician burnout is happening, but they're not willing to measure the pervasiveness of this problem as they are unsure of what to do with the results of these measurements. For years, the topic of burnout has been taboo amongst providers. Certainly, the research says that there is a problem. However, if you were to ask your colleagues, it's unlikely that you would get a good sense of the scope of how big of the problem burnout is. From the very first days of medical training, healthcare professionals are encouraged to give all of themselves for the benefit of others, often foregoing sleep, family time, and even the bathroom to go the extra mile to treat that one more patient. With this mentality, we fostered the belief that speaking about fatigue is taboo. And if it was spoken about, it was often referred to as a perverse badge of honor. With this mindset, we have allowed ourselves and our colleagues to struggle in silence, often not taking meaningful steps to reduce fatigue, until it's too late. Now that we have seen how we have allowed fatigue to become such a large issue, we need to take a look at how we can start taking action to solve the problem in practice. One of the first steps is to identify the scope of the problem. The easiest way to identify this is to conduct an anonymous survey. The Maslach Burnout Inventory, Human Services Survey for Medical Personnel, is recognized as the leading measure of burnout and has been extensively studied and validated in the more than 35 years since the initial publication. The survey is a great first step to evaluating how widespread burnout is in your practice. Here's a brief example of what the Maslach Burnout Inventory looks like. As you can see, each item is scored on a 7-point scale, ranging from never to every day, and is tailored specifically to the healthcare practitioner. The questions on the survey cover feelings directly related to burnout, such as feeling emotionally drained from my work, and I don't really care what happens to some patients. As well, some of the questions gauge feelings of achievement and accomplishment, which can mitigate the feelings of burnout. Now, as a general piece of information, this survey can be found at mindgarden.com, but this is only one of a variety of surveys available to measure practitioner burnout. So in addition to conducting a validated survey, you can also solicit feedback about burnout in your practice by conducting informal provider focus groups. These are often great as lunchtime activities and can help providers talk freely about stressors of practice. If they're conducted in an open and non-threatening manner, these meetings may allow practice leaders to better understand the energy levels among providers and help determine the scope of fatigue in your practice. In addition to office meetings, you can provide an online anonymous suggestion platform that allows providers to provide suggestions and feedback without fear of retribution. There are many great ideas out there in practices, but oftentimes there's no centralized suggestion platform for employees to provide information to management to help engender changes to reduce fatigue and burnout. Oftentimes, frontline providers know exactly what they'd like to do to reduce their burnout, but their voices do not have a path to be heard. Conducting surveys on provider preference is also another more structured way to gauge the impact of practices on provider levels of fatigue. This survey should be conducted anonymously for optimal results. Another way to measure fatigue is to establish work groups between practice leaders and providers to help investigate the ways providers are feeling and the impact of that fatigue on the office. These groups can have a powerful impact in bringing pain points to light that are making physicians and practitioners feel burnout. Now that we have talked a lot about provider fatigue and burnout, we're going to discuss some ways practices can reduce the associated burden. Reducing practitioner workload is an important factor to reduce burnout. However, one of the most direct ways to reduce practitioner workloads is by adding more practitioners. Unfortunately, adding more practitioners increases overhead and leads to a less efficient practice. This is not something we want to do when trying to make everyone's life easier. Reducing after-hours on-call demand can go a long way towards reducing provider burnout, as it allows time for providers to decompress and reduce the amount of downtime devoted to patients outside of working hours. Changing practice staffing plans and training your staff to participate more in your patient's care can be a great way to control provider fatigue. As we'll later discuss, a registered nurse co-visit model can be a great way to use your staff more effectively to reduce burnout and improve satisfaction. By some estimates, practices are only using 10% of their staff's skill set. Providing staff with a greater role in patient care can help benefit your providers, your staff, your patients, and your practice. One example for providing staff with a greater role is training your front office staff to informally triage your waiting room so the simplest cases can be seen first. This model will allow you to get the most patients through your office in the least amount of time while reducing the feelings of pressures that come from a full waiting room. This throughput can improve your office workflow dramatically and reduce the stress and help reduce feelings of burnout and fatigue within your practice. One of the principal ways that a practice can reduce after-hours call demand is to utilize telephone nurse triage. This reduction in after-hours call demand can have a substantial effect in reducing physician burnout and fatigue. This is a great way to handle up to 95% of patient requests to speak to a provider after hours. The telephone nurse triage provides 24-hour access to care and advice by qualified and experienced registered nurses. These nurses provide care and advice based on evidence-based peer-reviewed guidelines and established protocols to ensure consistent and medically sound advice. These nurses have access to a physician to provide backup advice if need be, and the service can be provided either by a dedicated team of staff located in the practitioner's office or by a third-party nurse triage call center. An excellent alternative to providing in-house after-hours nurse triage is to utilize a third-party nurse triage service to serve your patient's needs. Nurse triage services are based in a call center and are staffed with experienced registered nurses with the sole job of helping your patients with their medical questions after hours. The call center is overseen by a physician dedicated to the call center operations, and the nurses also have access to the practice on-call physician. This process provides prompt care and advice 24 hours a day, 365 days a year. Many practices report excellent levels of patient satisfaction when they provide patients access to nurse triage lines. Oftentimes, when patients are asked after a nurse triage call where they would seek advice if they did not have access to the nurse triage line, their response would be to go to the emergency department. Frequently, patients report that they're unsure what to do when they have a medical question after hours. These patients often turn to the internet, friends, or family, or simply call 911. The lack of access to quality advice after hours leaves patients to spending hours and money at emergency departments and urgent cares unnecessarily. Many patients report dissatisfaction when their practice simply refers the patient to the emergency department without screening the patient first to determine the best location for care. Patients often present to the emergency department upon the practice's recommendations and are sent home from the emergency department with receiving only minor care and instructions to seek follow-up care with their primary care provider the following day. Providing well-established nurse triage services can help reduce these occurrences for your patients and help maintain confidence in your practice while retaining patient visits as well as reducing provider burnout. There are many advantages to partnering with nurse triage services as opposed to staffing and maintaining a line in-house. From an operational standpoint, there's a better surge capacity to handle busy times. A third-party nurse triage service has optimal staffing levels to handle a large volume of calls at a moment's notice. With a third-party service, there's no need to manage a continuous quality assurance program. Continuous quality assurance programs are key components to any legally defensible nurse triage line. If you're providing nurse triage without a continuous quality assurance program, you're taking unnecessary risks with your nurse triage program. Finally, a third-party triage service has superb documentation on every call. They provide call recording for every call, as well as have scribe capability after hours. This documentation, recording, and scribing allows for all of the care provided over the phone to be properly documented and defensible in the event that something doesn't go right. Some services offer scribe capability that allow any on-call physician who speaks with a patient the option of having the nurse scribe the note for the provider so that the note can be ready for the provider to sign when they get back into the office. This feature ensures that your on-call providers can spend more time enjoying free time and less time worrying about writing notes from on-call phone encounters. This reduction in on-call encounters will help reduce provider fatigue and burnout. Now, in terms of decreased costs and increased revenue, third-party nurse triage services can save a lot of money as you only pay for the nurse when you're using them. You aren't paying for the idle time where the nurse isn't answering phone calls or trying to maximize their productivity by task switching them into a different task within the practice. Once you free up your staff by using a third-party nurse triage line, you can use your nurses for other services that you can bill for, such as registered nurse co-visits, or even simple wound care visits. Also, with a third-party service, you have no training or software costs, and you're not responsible for paying extra costs in staffing and utilities for running your operation 24 hours a day, 7 days a week. Many practices use medical after-hours answering services. This is a very risky practice when compared to nurse triage. With medical after-hours services, your patient speaks to a non-medically trained operator who takes the patient's information, screens the call with some cursory questions, and then cues the call for provider feedback. This method is dangerous because you do not have trained expert nurses assessing each caller and obtaining as much information, both nonverbal and verbal, to make a determination as to the severity of the caller's complaint. Without a nurse making this determination, it is highly likely that patients calling with severe conditions would be told to wait for a provider's callback, or the patient would be unnecessarily sent to the emergency room while experiencing a less than urgent condition. Waiting too long for a provider to call back can lead to a bad outcome, while over-triage and sending all callers with general symptoms to the emergency department can lead to decreased patient satisfaction. These two outcomes can easily be addressed by utilizing well-trained professional nurses to assist in determining who can safely be seen in alternative care locations or times, and who should seek emergency treatment in the emergency department or by calling 911. Additionally, the use of evidence-based protocols and quality assurance programs provide consistent and medically sound care at all times. The documentation of advice and the delivery of electronic aftercare instructions can further establish the presumption of quality care via telephone. In addition to the benefits we've already discussed regarding nurse triage services, they can help recapture visits that you would otherwise lose to urgent and emergent care during off hours, and ensure that well-documented defensible care is provided over the phone. Additionally, nurse triage lines can save patients time and money and ultimately increase patient satisfaction while reducing provider fatigue and burnout and improving provider satisfaction with their personal practice of medicine. Now, I want to share a case study about how nurse triage has increased productivity and reduced burnout in one practice. This article is from 2015 in the Journal of General Internal Medicine by Karen Funk and Malia Davis. Funk and Davis worked at the Clinica Family Health Center in Lafayette, Colorado. And this practice took a unique perspective. They decided to develop a workflow shift that resulted in a positive impact on their providers, staff, and their patients, while increasing the productivity of their practice. What the clinic did was they shifted nurses from the office triage lines to help with patient flow by utilizing a registered nurse co-visit model. Now, this co-visit model allowed for nurses to leave the phone lines and return to their role within the practice. Previously to implementing this change, they had seen that almost 95% of their visits, their patients had no interaction with a registered nurse because the nurses were so busy conducting phone triage and other office tasks, they weren't truly providing patient care. The model required little provider time, but utilized nurses more effectively in order to provide patient care. Prior to this shift, there were a lot of triage calls that they were unable to provide visits for, as there was no more room for same-day patients who had urgent needs. So essentially, callers were calling the practice and they were asking, I have a sore throat, I have a fever, something that could be handled in the office. And they were told that unfortunately there was no ability to see them in the office. So they were then referred to an urgent care center. And that is obviously much more expensive for the patients, and it can take a considerable amount of time as opposed to simply coming into the office and being seen by the practitioner the same day. Now, this put a lot of stress on nurses and practitioners in the practice, as they felt they were often unable to help treat patients who needed them on an urgent time frame. Now, in an attempt to accommodate these needs, the office actually had to permit double booked appointments. Now, as many of you know, double booked appointments are not an excellent opportunity for patient satisfaction. Patients had increased wait time, and also decreased patient satisfaction because the office was so overbooked in order to provide care to the patients. Nurses were also frustrated. They were unable to assist patients as they were busy answering the phones, and they couldn't help with this office patient flow. So the nurses felt that they could be serving their skills if their skills were better utilized and put into practice to actually help their patients. After much discussion, the clinic moved telephone triage out of the responsibility of the office nurse. In return, the nurses were able to be repurposed to provide RN co-visits to increase the practice's capabilities. The clinic ended up staffing the triage lines through a dedicated position in-house. However, these results could have easily been obtained by using a third-party nurse triage service at an even greater savings. Now, one of the most impactful quotes from the case study was one nurse who explained, "Triaging with no access creates only more work, electronic tasks to finish, and extra phone calls. I hate telling patients to seek urgent care when I knew we could help them here if we had space." And that was a surprising finding in this case study, as they were not expecting to have patients, or rather to have nurses, feel so passionately about the phone triage process and how it was taking them away from providing the care to their patients. Now, the co-visit model essentially retrained nurses to serve as an extension of providers. The nurses were freed from the telephone triage position, and they were able to assist providers in seeing same-day patients with simple yet urgent needs. When the patients arrived from the same-day urgent appointment, they were slotted into an exam room. Next, the nurse arrived and elicited and recorded a history of the present illness, past medical history, family and social histories, obtained vital signs, implemented pertinent standing orders, and created a nurse note. When the provider entered the room, the nurse presented the history to the provider in front of the patient, allowing the provider to clarify any details. At this point, the nurse immediately switched to scribe role. In scribe role, the nurse was responsible for documenting the provider's physical exam, the assessment, as well as the plan of care for the patient. After the provider finished with the exam and relaying all the information to the patient, he moved on to the next patient encounter. This left the nurse to review the care plan and provide appropriate education with the patient, as well as any other referrals or treatment that was required within the scope of the nurse's practice. Later, the physician was able to quickly review and authenticate the visit documentation before submission for billing in accordance with the Center for Medicaid and Medicare Services guidelines for validation. This arrangement in this study allowed for the practice to increase their daily visit capacity by 12 to 17%. It also allowed them to entirely eliminate double booked appointments. This had a great impact on the waiting room, as well as the provider's psyche when they were walking into the waiting room or realizing that the waiting room was not as packed as it was previously. The patients were very satisfied with the results and rated the care at 9.5 out of 10 on patient satisfaction, one of the highest levels of patient satisfaction that this office had received. The rating was above the normal baseline for provider-only visits. Patients also reported feeling that they were cared about and that the provider spent more time with them than they rated in a regular visit. The practice was able to increase daily visits by an average of 2 patients per provider. The co-visit took approximately 20 to 30 minutes in total and only required 10 minutes of the provider's time. Additionally, the co-visits were used to help fill holes created by no-show patients, even further increasing efficiency in the practice. The practice was able to increase access and job satisfaction, with some providers reporting that since they implemented this switch, they left work on time with their charting complete for the first time in years. Nurses also loved the new model, affirming that they felt valued and inspired to develop their skills. As demonstrated in this case study, utilizing an RN co-visit model is an excellent way to redesign your practice to help reduce physician and provider fatigue. Nurse triage services can enable your practice to try the RN co-visit model. The co-visit model plus an after-hours nurse triage service can lead to an even greater reduction in burnout by reducing the amount of on-time call providers are required to take and the amount of time that they're required to speak with patients during nights, weekends, and holidays, pulling them away from other enjoyable activities. Today, we covered a lot of information detailing the scope and impact of provider fatigue. We talked about ways to measure the level of fatigue in your practice and even suggested some realistic solutions to help improve your provider and patient satisfaction while reducing the amount of burnout amongst your providers. Now, I hope this presentation has been informative and helpful in making your practice an even better place to work. And we look forward to taking some questions now at this point in the presentation.
Thank you, Brad. I'm now going to read some of the questions from the question box. If you have any additional questions, please type them in the question box located on the right of the screen now. The first question is, will the slides be available later? And that is a yes. I'm going to email every participant a copy of the presentation slides, and a recording of this webinar will be available as well. The next question is, did I miss the financial ROI of this increased service level effort? While the cost of turnover is impactful, the cost of keeping all at limited levels will have a fiscal impact.
Okay, so if I'm understanding the question, we're asking about the ROI of adding this service to your practice and helping it reduce physician fatigue and burnout. So let me go ahead and bring it down to the ROI slide here, not the ROI slide, but the slide where we talk about the cost here. Bear with me for a moment while I find that slide. Okay, that's going to be slide 14. Okay, so when we're looking at, the cost of physician fatigue to a practice, we do see that there's a large amount of revenue that is lost, between $500,000 and $1 million a year in just practice revenue. The recruitment cost on top of this is $90,000. And obviously reaching out to increase the service level to provide nurse triage is something that we would be happy to discuss with anyone who's interested in having a conversation at a later point, as we need to tailor it specifically to each practice and the requirements that each practice has for nurse triage.
Okay, we don't have any further questions. We could give a few seconds if anyone has any more. Okay, so if there are no further questions for the day, then we can wrap this up. Once again, the presentation slides will be emailed to all participants and will be available on our website for members only. If you have any additional questions, please feel free to reach out to the presenter directly. Thank you, everyone attending, and thank you, Brad. I hope everyone has a great day.
Take care.